This podcast is sponsored by GSK. Learn more at gskpro.com.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello and welcome to all of ReviveFM audience. It's my great pleasure to be here today hosting this episode. It's me, Nowal bin Jalalah, family medicine resident, R2 in King Fahad Military Medical Complex. In today's episode, we will be discussing a very important topic for us as primary care physicians. According to the World Health Organization, health is defined as a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. Today, we will be tackling the mental and to some extent the social health, which are very important pillars because they determine how a person relates to others, handles stress, and make healthy choices in life. And speaking of mental health, drug addiction or substance use is considered one of the mental disorders, and it has its own DSM-5 criteria. Unfortunately, the number of substance users is increasing worldwide, and according to a recent United Nations statistics for annual global use of drugs, it's estimated that 219 million of population are cannabis users,
wow,
and 60 millions are opioid users, and around 21 millions are cocaine users, and 37 million are amphetamine users. We're here talking about huge numbers, mandating us as family physicians to raise awareness and to have the proper knowledge and the proper skills to approach these cases in the clinic. So before we start this episode, I would like to introduce you to our guests, Dr. Nisar Yaseen, family medicine consultant in Johns Hopkins Aramco Healthcare, specialist in pain management, MRCGP certified, postgraduate certificate in medical education, senior resident trainer, and co-chairman of Patient and Family Advisory Committee. MashaAllah. Long list.
Assalamu alaikum. Jazakallah khair for that very kind introduction. It's my pleasure to be here, part of this team, and I hope that this podcast will be of benefit for our listeners, inshallah.
Bi'idhnillah. We're very happy and we're very glad to have you here today with us, Dr. Nizar. Our second guest, Dr. Dania Badghaish, family medicine registrar, recent Johns Hopkins Aramco Healthcare.
Thank you.
Welcome,
thank you,
Doctor.
Thank you, Noel. I'm glad to be here, and hopefully it will be an informative episode.
Inshallah. Last but not least, Dr. Feras AlQahtani, general practitioner attached to family medicine department in King Abdulaziz Air Base Hospital. Welcome, Dr. Feras.
Thank you. I'm very happy to be here, and hopefully this will be a very informative episode for us as well as the listeners.
I'm pretty sure, inshallah, it's going to be a great episode. Let's start our episode with a real-life case scenario, which was seen by Dr. Nizar in his clinic. He shared it with us while preparing this episode for educational purposes. It's basically a 38-year-old lady, divorced with no children, currently living with her parents and siblings. Upon reviewing her medical history, she's known to have PCOS, mild thoracolumbar scoliosis, and chronic back pain for the last 5 years. She's shisha smoker, her BMI is 30, and looking at her medication list, she's on metformin, celecoxib, and cocodamol 2 tabs TID. Can you tell us, Dr. Nizar, what made you suspect that there's some element of drug abuse or addiction in this particular case?
Inshallah. Jazakallah khair and assalamu alaikum. I just want to start that normally before I see any patient, before I call them in, I have a quick review of their medical records, and that's one of the advantages of having an electrical medical records. It's easy to get an overview before calling the patient. It just puts you in a good kind of standing before they come in.
You're right.
So when I reviewed her notes, there were a couple of things that I noted. One, that she was a frequent attender to both primary care and to the emergency services. She was seen in primary care in different clinical settings, including the urgent care, the walk-in, and routine appointments.
Okay.
And most of her clinical encounters were with not her own primary care physician, but with various doctors.
Okay.
She had a history of chronic back pain for 5 years, but she hadn't seen a pain clinic doctor for over 4 years, and she had missed appointments.
It's a long time.
Absolutely, and with no follow-ups as well. Not because they weren't offered, she cancelled.
Okay.
She's been on cocodamol now for 4 years, which is a long time. Okay. And then I also had a review of her notes, and it noted that she was taking a lot of sick leave. And when she came in, when I saw her, she had bags under her eyes. She was looking tired. She said she couldn't sleep because of the pain, although she didn't like. She was in a lot of pain. There was she was living with her parents. She was divorced, and there was a history of kind of domestic abuse or violence at home.
Okay.
So, sorry for interrupting, but did the patient have like any family history of psychiatric illnesses or substance abuse disorder?
Which is interesting, because when I was reviewing her notes, I recognized her surname and some of the details that she had. And I recalled that her mother is also my patient, and her father. And the mother had significant psychiatric illnesses with bipolar disorder. She also had chronic back pain and had been on long-term cocodamol and tramadol.
So she did have family history.
Yeah, so there was a kind of family history of the psychiatric illness and drug abuse. And actually, when the mother came with her husband, their interactions were very kind of erratic, and they were often arguing. So that was another thing that kind of made me concerned and suspicious.
So multiple clues.
Absolutely.
Okay, so it's very important to look at the patient from all aspects, including family history, previous visits, and all what you've mentioned. But of course, before labeling a patient to have a substance use disorder, there must be a scientific criteria that must be met.
Absolutely.
Of course. But before the criteria, I actually had a question for Dr. Nizar.
Sure.
So I once had a patient in the clinic who frequently attended rave parties and consumed substances. So from your experience, Dr. Nizar, what are some other features that are maybe seen in different populations, such as younger populations, or less commonly seen features in substance use disorder?
That's a very good question. So the symptoms and the signs that I just kind of went through were relevant to this patient. There's a crossover with other types of drugs that can be abused. But, depending on what drug is being abused and what route of administration, they can present with other symptoms. For example, with alcohol, they may have abnormal blood test results, alcohol-related issues. They can have other physical illnesses like weight loss. They can look cachectic, lack of energy. If they are using intravenous drugs, they may have some track marks. They may have recurrent boils or skin infections. They may present with new onset or exacerbations of mental illnesses. They can have changes in their behavior, and their appearance can be unkempt, and they may also present with financial problems as a source or the reason for visiting you. And they may even have had exposure to the police because of a criminal activity. So depending on the drugs and the age, like you said, and the demographics, there are some other symptoms that they can present with. So it's always important to be aware.
Yeah, very diverse.
So going back to the criteria?
So in regards of the scientific criteria, the DSM-5 actually mentions that all drugs that are taken in excess have in common the direct activation of the brain reward system. They produce such an intense activation that normal activities may be neglected. It also recognizes that certain individuals, specifically those with low levels of self-control, are predisposed to developing substance use disorders. Sure. This suggests that the roots of substance use disorders for some people can be seen in certain behaviors long before developing the disorder, as we have seen in the case that Dr. Nizar presented. So actually the DSM-5 and the ICD-11 recognize 9 classes as the most commonly seen classes in substance use disorder. So what do you think are some of these commonly seen classes?
I would say, please go on.
And as I mentioned before, you've got the opioids and you've got alcohol, probably the most common, but there are others.
Even cannabis,
Absolutely.
as I mentioned in the introduction.
Exactly. These are all commonly seen classes, but I would like to stress that the commonly seen classes can actually differ from an area to another area, from a culture to another culture. So what's common in Saudi Arabia might not be so common in Canada,
Absolutely.
might not be so common in the US. So some of these classes include hallucinogens such as phencyclidine, inhalants such as glue, fuel or paint, sedatives such as benzodiazepines, stimulants such as amphetamine and other unknown substances as well. In general, the DSM-5 mentions 4 pillars that construct the concept of substance use disorder. So what do you think are some of these important pillars?
Risky medication use. Hazardous waste.
Exactly. Risky use, which is usually recurrent use that is physically hazardous, persistence despite psychological or physical side effects. So what do you think is another pillar of substance use?
The problem with having drugs on a regular basis is that they have the urge to take more and more, and may even get withdrawal symptoms.
Exactly. So impaired control is another pillar. So we see patients use a bigger amount or use it for a longer time than intended. We also see social impairments such as failure in work, school, or home. And one of the most important pillars actually is pharmacological criteria, like tolerance and withdrawal. Without them, we cannot make the diagnosis of substance use disorders. So each of the 9 previously mentioned classes carry their own specific diagnostic criteria, but these 4 pillars are shared within all of these classes.
All right.
Interesting.
Which is very interesting. I think when you in the DSM-5, they say, depending on how many of the symptoms a patient exhibits, can give you an idea of how severe the problem is. Whether, compared to 1 or 2 symptoms or up to 6 to 8, will help you define whether it's mild or severe.
Excellent.
All right. Is there any specific duration in the criteria mentioned, Dr. Feras?
So the timing and duration are not the main aspects in the diagnosis of any class of substance use disorders.
All right.
It focuses more on the diverse set of signs and symptoms as well as the effect on the activities of daily living.
All right, I see. I asked you about this in particular because it will take us to a very important topic, which is drug tourism phenomena.
Yes.
If you can tell us about it.
It's, drug tourism is actually, quite commonly done, but not well known. So essentially drug tourism is when a person undertakes a journey individually or as a group to a country or a place where access to drugs are a lot easier, or because the drugs are cheaper, or because access to those drugs are difficult in their home country.
Could be legal.
And it could be illegal, absolutely. So inquiring about their travel history or knowing that the person is traveling a lot, there is some benefit in asking where they have been, how often they go, who they go with, because certain countries, it's a lot easier to access drugs. And so going there is a way of them fulfilling their desires and their urges for the drug. So knowing where they've traveled to and being aware or looking on the internet, there's lots of online resources which will tell you which countries have easy access to the drugs. It's just another way or another kind of a risk factor or a hint that something's going on.
It must be looked at in the history.
Absolutely.
It's good to highlight this for all the family physicians watching us. Now we will go on a break. We will be back soon, so stay with us.
Shingles is a painful disease that can have serious and long-lasting complications. And the burden of shingles increases as the person ages, with a steep increases in adults above 50 years due to age-related decline in immunity. Shingles vaccine can provide up to 90% protection against shingles. Saudi Arabia's Ministry of Health recommends 2 doses of Shingrix, 2 to 6 months apart, for all adults ages 50 years or older in their national immunization schedule.
Welcome back, our audience. Now we will continue our episode with very important part. As we've covered definition, risk factors, important aspects in history, now we want to know how can we screen for drug use disorder during the clinic.
So the US Preventive Service Task Force published a Grade B recommendation to screen by asking questions about unhealthy drug use in adults age 18 and older. Screening should be implemented when services for accurate diagnosis, effective treatment, and appropriate care can be offered or referred.
All right. So that's for adults aged 18 and above. What about other age groups like pediatrics and adolescents?
So the recommendation is to screen adults, as you said, 18 and older, including people who are, or women who are pregnant and postpartum.
Okay.
Regarding younger adults aged 12 to 17 years, there is an I statement concluding that the current evidence is insufficient to assess between the balance between the benefits and harms of screening for unhealthy drug use in adolescents.
Sure.
The almost 80% of pediatricians report routinely screening for substance use disorder in adolescents.
Despite the recommendation?
Yeah, despite the recommendation. So, Dr. Nizar, what are your thoughts about screening in younger population?
Yeah, I mean, it's interesting about the recommendations, but I think it's important to take each case on its individual own merits. I suppose, for the younger children, babies who aren't independent, you need to be considering or be aware, are the parents into drugs, or is there any abuse going at home, or are they exposed to an environment where there's drug abuse, smoking, alcohol, which may help you understand what the problem is going on with the child. If you suspect that, then it's worth doing a screen. With older children now, children these days, a 12-year-old is more mature than an 18-year-old in the past.
Yes.
Especially with social media and things like that, there's a lot of influencing. The more independent the children have access to, easy access to drugs. So if you suspect that they are, based on their symptoms or how they're behaving, again, I think it's sensible to do a test for it.
Agree.
So
even if the patient is not diagnosed with substance use, if he's at high risk, we can write that down. And
if nothing else, you can put it down as a differential diagnosis.
Exactly.
Okay. And if you need to treat them with in a different normal way, and if they're not improving, I think it's something that you need to kind of reconsider and revisit.
You're absolutely right. So adding on what Dr. Nizar said, there are some brief screening tools that can be found on the NIDA, National Institute on Drug Abuse website. It has multiple screening tools, self-answered or clinician-administered questionnaires.
Okay.
They ask questions about the use of alcohol, tobacco, non-medical use of prescription drugs, and illegal drugs. Tools as TAPS, 8-item assist, and PSTAD. All of these can be found in the prescription box below.
Okay.
And you can find the link. So, doctor, asking patients such questions can be difficult. So
Very
can you
difficult.
give us give us tips or suggestions?
Yeah, I agree. It can be very difficult, and also depends on which culture and environment. In the UK, it was easier to discuss alcohol use. In this environment and this culture, it can be very difficult. So there's a couple of techniques I use. One is by not directly assuming or giving the suggestion it's the patient's problem. So an example would be, I would say, look, I have other patients who are on regular cocodamol, and they often say that they find it difficult to stop or come off it, even though they don't need it for pain, and they feel that they are becoming addicted to it. And then I'll say, do you have any of those feelings? So it's like an indirect way of getting them to open up. I'm not saying that they have a problem, but have you felt anything like that? Sometimes they need a slightly bit more direct approach, in which case I normally start off with saying, I'm really sorry. I understand the question I'm going to ask you may be upsetting, but I really do need to ask you some questions, and then you can broach things like alcohol and this. That kind of lets the patient know that, we as a doctor understand it's difficult. Okay.
Yeah.
We are being sympathetic, and also we're giving them permission that you can tell me, and hopefully they will feel more confident in us.
Exactly. And that we're not judging them.
Absolutely.
So let's say that we've screened the patient and now we're suspecting that there's some element of drug abuse. Is there any investigations that can't be sent?
So, there are no routine necessarily screening tests that will help with a diagnosis of substance abuse.
Okay.
There are some blood tests, urine, and other tests that can be used, but mainly those are used to help with the recovery process and see how they are doing, whether they are abstaining from the drug abuse.
All right.
So I normally would recommend doing a set of blood tests, based on the fact they are using substance misuse, their risky behavior. So a CBC would be useful to, get an idea of their level of nutrition, doing a renal and a liver function test to see any end organ damage because of alcohol and, if there's any hepatitis. Thyroid function test, because thyroid disorders can mimic psychiatric illnesses. So those are kind of routine ones. And others would be depending on what kind of risky behavior or other suspicions. For example, if you think they are IV abusers or they're at risk of sexually transmitted infections, do an STI screen, including HIV and a hepatitis screen.
Okay. All right. So you mentioned STD screening. That means drug abuse is associated with multiple comorbidities and multiple risky behaviors. If you agree with me, Dr. Dania?
Yes, of course. So what do you think are the risk factors for such behavior?
So people of younger age. So if a patient has already been prescribed a medication for pain,
That's
as
right.
an example.
Disability, yes.
Disabilities, yes.
I mean, similar to my patient, if there's a family history of psychiatric illnesses,
You're right.
if there's a kind of a history of domestic abuse or a erratic lifestyle and home life.
Yes. So aged from 18 to 25 years, male sex, having a mental health disorder, personality or mood disorder, nicotine or alcohol dependence, history of physical or sexual abuse, as you said, parental neglect, drug or alcohol addiction, and a first-degree relative. Misuse of prescription drugs include history of other drug use, as the case, pain, a greater access to prescription drugs. Risk factors for younger adults include aggressive childhood behavior, lack of parental supervision, poor social skills, access to drugs at school, and community poverty. What complications do you think what complications do you know?
So maybe these patients are more likely to skip school since they're between 18 and 25.
You're right.
Maybe they're more criminally involved. I would think of these 2 points.
Yeah, I mean the consequences can be physical, mental, or social. Direct impact on the patient and people around them. So there are different kind of stakeholders who can get impacted by their behavior, like you mentioned, school and work, the family. Divorce rate, I suspect, would be much higher.
Overdose is very important as well.
Overdose. So adding on to what you said all. So suicide, overdose, unintentional injuries, violence, especially in young adulthood, increased risk of STI, as we mentioned, other health problems, unintended pregnancies, criminal involvement, and school truancy.
Very excellent. Beside all of this negative physical and mental impact, there must be a huge negative social impact, if you agree with me, Dr. Feras.
Of course. So, as we said, substance use can impact a person's life in multiple different ways. So, let's take the social aspect, for example. As we said, we see higher rates of divorce, we see lower rates of education. People are more likely to give up hobbies and interests. That lowers their quality of life.
Right.
In terms of family, we see more unstable marriages, higher rates of domestic violence, lower family income. And in terms of work, and this is actually very important, we see higher rates of unemployment. So now that we know the facts and we know that it affects patients severely, what can we as family physicians do? So we now know that screening for substance use is indicated and recommended for all patients who are 18 years and older.
Yes.
But sometimes in the clinic, it is difficult to screen all the patients due to time constraints.
Right.
So in that case, a more realistic approach is when seeing these social and familial cues that we discussed previously, they should be red flags for any patient that presents to our clinic. The presence of any of these signs should encourage us to screen for substance use disorder with the tools we have mentioned, regardless of time constraints in the clinic.
I agree.
Certain age groups, such as adolescents and teenagers, are more likely to be peer pressured into substance use disorder, and screening in these age groups could be beneficial.
That's right, yeah.
Another important point is that our culture, religion, and beliefs can have a major impact on the features of substance use disorder. For example, the United States Preventative Services Task Force recognizes that people between 18 to 25 are at higher risk of developing substance use disorder.
Yes.
Multiple case control studies in Saudi Arabia show that older age is a risk factor in our region. So, given the burden of drug use, I would say that more research is needed in our area on approaches to identify and effectively intervene with patients exhibiting risky patterns of drug use, or more importantly, low self-control in primary care.
I totally agree.
Absolutely. Those are very kind of important points. I'd just like to add on, the studies show various demographics are at higher risk, but just be aware, I think it's important for our readers to be aware that just because they may be well educated, maybe they have plenty of money, live in a big house, drug abuse and substance abuse is still an issue.
Yes.
Another point I'd like to say is, being in the community and family medicine, we're in an ideal position to understand our community, know our schools, know our patient population, know the socioeconomic status of them. It just kind of gives you a deeper understanding of what's going on outside.
Exactly.
And the impact of what's happening outside on your patients.
Absolutely. All right. So at this point, we know how to approach these cases in the clinic. But how can we manage them, Dr. Nizar? Do we really always need to refer to psychiatry?
Interesting point. There's lots of guidelines available online, various associations on how to manage substance abuse, who to refer to, what to do. But it's important to realize that these guidelines are not set in stone. It's important that we take each patient and assess each patient and manage them as an individual, as a person.
Exactly.
Okay.
We're not treating substance abuse disorder, the diagnosis. We are treating a person with substance abuse disorder. And that's where you highlighted this biopsychosocial model is very important. It impacts various stakeholders. My approach to this is, and I find we as family medicine specialists are often the first people to find out that they have substance abuse.
Yeah.
And in the culture that we live in, it's not an easy diagnosis or a admission to make from a patient. Absolutely. So, we're in a privileged position to be able to help our patients. And what I found that helps most importantly is to assess the patient as an individual.
Okay.
Holistic view. And the pivot or the cornerstone of this is to develop a trusting relationship which is non-judgmental, so that the patient is comfortable with telling you how they are, and coming back to you for support and advice. And based on that, you can then refer them. At the end of the day, you do need a multidisciplinary approach. Okay. You won't be able to manage everything yourself. So members of the MDT would include psychiatrists, psychologists for things like CBT, behavioral treatments, social workers, occupational health for work-related issues, and other specialties as needed, such as gastroenteritis for hepatitis or infectious diseases. But the main thing is, like you said, the cornerstone of it is a really good relationship, trusting relationship, and good rapport with your patient.
I totally agree. Unfortunately, we're coming to the end of this episode. But before we end, I would like to ask you, Dr. Feras, if there's a hotline number you can share with us that we can provide to substance users in the clinic or to their families.
Sure, of course. So all patients or family members who face any addiction-related problems can contact the Ministry of Health through the number 937 with the extension 5, and they can talk directly to a physician to take their history and guide them to the proper facility for the proper care with complete confidentiality regarding the patient and his family.
Good to know.
All right. So it's 937 extension 5.
Yes.
All right. This will bring us to the end of this episode. Substance use disorder is a very lengthy topic, and mashallah, you all covered it amazingly today. Before I conclude, I would like to give you the mic, Dr. Nizar, to give us the take-home message.
Thank you very much. My take-home message from this is we haven't covered everything. There's a lot to this, but the most important thing is you need to be aware that substance abuse is a growing problem in the community around the world. Be aware of that. Be aware of the risk factors, red flags that may indicate that your patient is having this issue.
Very important.
And like I mentioned before, our role, most important role, is to be an advocate for our patients.
Yes.
Develop a trusting, non-judgmental, supportive relationship with your patient, and
Always.
you will help them through their journey. The journey will be up and down, but you need to be there as a cornerstone to their journey.
Of course.
You're absolutely right. Thank you so much for this
thank you very
valuable
much
message.
Thank you.
Please always remember that we, family physicians, have a very crucial role in detecting and managing substance use disorders, especially that we are the first-line actors. I hope you enjoyed this episode as much as I did. For further details, please check the description box and share this episode with all physicians you know. Thank you so much, our cameraman, Dr. Mshari Shreem. Thank you so much, Dr. Nizar.
Thank you
so
very
much,
much,
Dr.
Jazakallah
Dania.
khair.
Thank you so much, Dr. Feras. في أمان الله.
This podcast is sponsored by GSK. Learn more at gskpro.com.